Hi, everyone. I'm Dr. Rebecca Griffith, the ED-DPT, and this is Admitted or Not, the podcast of the ED-DPT, a podcast for physical therapists and others who practice in the emergency department. And today I'm so excited to have with me Dr. Keith Roper. Do you want to introduce yourself?
Sure. Thank you, Rebecca. I appreciate the opportunity to be here and talk about this. My name is Keith Roper. I'm a physical therapist in Salt Lake City. Spent most of my career in outpatient orthopedics, and about 6 years ago, I came to Salt Lake City. And after a short time in outpatient, found my way into the emergency department and spent 3 years there until COVID happened, and COVID kind of changed things for me a little bit. And currently, I'm in outpatient again, but hoping to get back in soon.
I love it. So before you came to Salt Lake City, you owned your own practice
I did.
in North Carolina.
No, Northern California.
Or Northern California. I misread that. My apologies. So why the change?
Well, the short answer is reimbursement. I had a thriving practice. I had plenty of patients, but it was really difficult to get paid in private practice, and insurance companies were competing to pay us less and less money, and it was harder and harder to get paid. And I was just working really, really long hours and not making very much money. That sounds bad, but the truth of it is, at the end of the day, I had bills to pay.
And a family to take care of. It's hard to do that.
Exactly. So it was really tough to make it in a tiny little town and a tiny little practice. So yeah, we just made the decision to change. But I think that really set me up to be a good person to be an ED. I've listened to a lot of the discussions about what's better, outpatient or inpatient.
Yeah, I'm going to ask you.
Yeah, absolutely. And so let's just get that right off the bat, because I think it's from all the people that I've talked to that practice in ED, we each have our own flavor on how we do it, which is obviously based on what our background is. And so it develops in the way that we're comfortable. But I think that my experience in a rural area, even though we didn't technically have direct access in California for most of that time that I was there, I was, in a small town, and everybody knew me, and everybody, people walked in the door. And so I had people come crawling in the front door with back pain because they knew I was the back guy, and so I also had to have the ability to see anything. For a lot of those years, I was the only PT, or, so there was a critical access hospital that had an inpatient PT for some of those years. But, for the most part, it was me for a whole bunch of people, and I had to be able to figure out anything. So
you're saying you were an emergency PT before you were an emergency PT?
Yeah, in a way. Yeah. I mean, most of my stuff was referral, but I did have a lot of direct access, essentially people walking in the door day one with injuries. So absolutely.
I love that. So that definitely helped you with your practice. And then when you've been in the emergency department, have you been full-time, or have you had more of a hybrid model of in and outpatient?
So the way it happened was I was kind of invited in by an ED provider. I was treating somebody for back pain in the outpatient clinic, and they had a really good response. They were in really bad pain, thought they were going to have surgery, a handful of visits, and they were back to work again. And they said to me, I work in emergency, and we see a lot of people with back pain, and we hate back pain because we don't know what to do.
Right.
What you did with me was really amazing. Have you ever thought about working in emergency? Because I would love to have you there.
Love it.
And so that's kind of the way I ended up in emergency. Was I said, well, that's a really cool idea. I'll talk to my supervisor. You talk to your supervisor. And long story short, I came in initially just sort of, I was on an observational status. I was like, let me be there for a few days and figure out, so I came in one day a week for a little while. And it's funny because the very first day I was there, one of the providers came up to me and said, hey, how do I consult you? I've got somebody over here with whiplash from an auto accident. Can you come see him? And I kind of said, well, we don't even know. I'm just here.
I don't work here.
I don't know. I don't work here yet. And he kind of got this annoyed look on his face, and it's just like, and I said, I'll be right there. And I went over and saw this person and gave him some advice, and did an exam and gave him some advice. And they were really happy. And the provider was really happy. He's like, okay, well, there we go. And it kind of went from there. But So I started off just a day a week, and it rapidly went to 2 days a week, and then up to 4 days a week. And for most of the time I was there 32 hours a week, and I kept one day in outpatient.
Mhm.
And I did it for a couple of reasons. I think I've my whole career has been outpatient, and I just couldn't quite wrap my head around not being there and having a caseload. But it also turned out really cool because we had a model where I had rapid access spots on my outpatient schedule. And so
Mm.
I could see the person in ED on Monday and say, you know what, I have a clinic spot on Thursday. I'll see you then. And so they were following up with the same person that they saw in emergency. And I loved that. And I used it quite a bit, and people really, appreciated that ability to see the same person.
I appreciate that because that's something that I get asked often. Is it going to be you that I see when I go to this clinic? Are you going to follow up with me? And what I usually tell patients is, I hope you never see me again.
Yeah.
Like, I hope you never have to come back here. I hope you never see me again. Like, maybe I'll wave at you out in the wild, which I recently had an experience where I had a patient that was running a business that I went into. And that was so cool just to see the patient like thriving and doing well.
I love it.
But that, patients usually want that continuity of care. And I find that it's very hard to just set up follow up appointments urgently.
Yes.
And that's an issue in physical therapy in general that I have a little bit of a soapbox on is if you wanted to see a chiropractor today, could you do that? Probably. I know you could here in Colorado.
100%, yeah.
So, but could you see a physical therapist today? Maybe, but you'd have to spend an awful lot of time calling around, and there would be like insurance barriers and cost barriers and time, it would be a thing.
All sorts of,
So
yeah.
I like that approach that you have. Are you going to continue doing that as you come back into the ED?
I'm going to propose it. I'm going to propose the same thing, 4 days a week ED and 1 day outpatient, just so that I can, because I really felt like it was valuable. And I have outpatients that I continue to occasionally follow today that I met 5 years ago in ED.
That's so cool.
And they'll pop up on my schedule every year or two. And it's like, hey, I won't see anybody else. You're the guy, I remember the day I met you. And, that's so cool. Yeah. It's like, I was actually before the ED, before the opportunity opened up for me to get back in there again. I was looking at another clinic that I might move to. And I was talking to one of my patients who I met in ED. And I hadn't really told anybody yet, but just kind of the way the conversation went. I said, I'm thinking about moving to this other clinic. And he said, well, if you do, let me know, because I'll follow you there. I was like, and it was, from meeting him in emergency and making a connection with him on that first day and making a difference with that person that day. So yeah, continuity of care is, I drive my supervisor crazy because I'm so passionate about it. And I just get angry when we can't do a better job of that in the outpatient setting.
Well, and that helps keep patients out of the emergency department, right?
Absolutely.
And if we had more proactive care, I think there would be less of that. And if we had more access to care, during the day, how many people can really go to a PT appointment? Yeah. Several, right? But like several people can't. And those are the patients that often end up coming to me in the emergency department because there's nowhere for them to go. They don't have the time or space to go, and they can't access that care.
Yeah. And yeah, we know how valuable early access to PT is with acute pain. And
100%.
Yeah, Julie Fritz and Jake Megalin, our group here in Utah published so much on the value of early access, but we just don't get it in our own clinic. We have a huge backlog to get people in, and so quite often they end up going to emergency. I've had many times, I'm sure you've had the same thing, where I'm in emergency, somebody comes in for back pain, and I go, yeah, I canceled my appointment in PT and came here today because my pain's so bad. And I'm like, oh my gosh. Guess what? You're going to see a PT.
Yes. Yep. And that's happened to me a few times as well. Or I'll see them and I'll say, hey, you have another PT appointment this afternoon. I still want you to go there.
I want you to go.
Because it's like your primary care, right? Like I'm the emergency PT, but I still want you to follow up with your primary care PT. And when I see patients who are being followed in our outpatient clinic, I will reach out to that PT. And I'll ask the patient's permission, but just like if it were their PCP, I reach out and say, hey, your patient was seen in the emergency department for these complaints. This is what I did. This is what I encourage them to do until they see you next. I think it would be a good idea for you to reach out to them as well, just so that they do feel cared for and that they're going to come back and see you. And I've had really great success with that. Had a little more trouble when those patients come in from home health,
Yeah.
being able to connect with the PTs that they are coming from.
No,
But I would love to be able to do that.
I love that idea. And I think that's so valuable, that just that contact, because, you know, a lot of times, and the literature on how many people come to ED for pain and never follow up with anybody, just off the top of my head, I want to say it's like 50%. It might be even higher than that, is really high. So they're in so much pain, they go to ED, but then they never see anybody in the next month afterwards, which is kind of an interesting comment on what is it that drove you to come in today. But having that ability to make sure somebody follows up on them to reduce the bounce back, I think can be just really, really valuable.
Do you think there's something that's happening in the ED that like discourages them from following up, or are we just assuming that everybody's a satisfied customer and their pain has magically gone away? Like, why aren't these people following up, do you think?
You mean the people that just don't seek care?
Yeah.
After? Yeah, I think that for a lot of people, I think it's they just really want to know, am I okay or not?
Mm-hmm.
And if they've actually been seen, been examined, had a diagnosis, been reassured that they're not going to die, then then a lot of people say, okay, that's what I needed. And I actually have a story about that. But I also think that in our older model, which is thankfully starting to change some, they go in, they get some medication, they get imaging and a medication, and they say, okay, well, that's what you get for back pain. And so they go home and continue to live. And so I think that there's a breakdown in education. And this is not a criticism of the physicians and other providers, but they don't appreciate what we do. They don't understand is what I mean by that. And so they have a difficult time educating a person on the value of making sure you do that PT follow-up. It's one of the things that I really loved about some of the relationships I developed with the providers in ED, that they were selling me harder than I was. They were selling PT. Like, you need to go to make sure you do your outpatient physical therapy, because they were seeing the value of it. And so that's one of the questions you asked on our form was, what's one of your biggest wins? And for me, I think it's really been that the relationships I've developed with providers, and having the providers come back and say, what you taught me changed the way I do this. I still do this thing, or ask this question, or tell people this because you taught it to me. And so that's just been a massive thing for me, because it's really cool to have those one-on-one stories that I saw this person and this thing happened. But if I can change a provider's understanding, then that's exponential.
Oh yeah, that ripples. That is huge ripples.
Yeah.
Well, one of the things that I feel like you and I have really connected on is how to manage patients with pain. And I know that you're a therapeutic pain specialist, but some people might not know what that is. So could you tell us a little bit about that, and then how you've seen this impact your care that you provide in this setting?
Yeah, so the therapeutic pain specialist, TPS, is a specialization that I got through a company called Evidence in Motion, which does a lot of physical therapy, advanced physical therapy training and fellowships. And it's really, really a deep dive into the anatomy, physiology, psychology of understanding the pain experience. Pain is really, really complex. You and I have talked about this a lot, and it's way more than just tissue damage. And we see that in emergency, people coming in because they're scared, because they want to know if they're okay or not. There's just really bad pain. So it's really understanding the physiology, understanding the overlap between very many different conditions, understanding how once you get the physiology of it, get the psychology of it, how can I take this information and help this person move past their fears, get past the physical barriers as well as the psychological barriers a lot of times. So yeah, it's a 6-month in-depth program to really help you understand and manage pain better. It really gives you a lot more of a whole person perspective, I think, on PTs. We're so focused on function and impairments, and identify the impairment and treat the impairment, but you forget about the person sometimes in front of you because you're so focused on the impairment. And I think that for me, it was already an approach that I tried to use, but the TPS has really kind of helped me come back around to a whole person approach and say, let's look at all of the factors that might be, or as many of the factors as I'm able to look at, to understand why this person is here today.
I think that's really valid because it's never simple.
Never.
No matter what setting you're in. I mean, I like to think that, the emergency department is very complex, but really, truly, no matter what PT setting you're in, and no patient is just what's on the paper in front of you. And my experience of you is that you do a very good job connecting with people to allow them to be more authentic and share really what's happening.
Yeah. And that's an approach. I don't know how that kind of came about in my practice, but it's something that I've tried to do for a long time. For years and years, I've said, if you'll just shut up and listen, the patient will tell you what's wrong with them.
Mm-hmm.
And then along the way, I've heard a few other people say that. It's like, that's what I say.
It's catching on.
But yeah, just to be curious and to sit down and ask a person to tell you their story and say, it's really interesting if you just ask that very open-ended question, tell me your story, where people will start. Sometimes people are taken aback by it and they'll say, well, where do you want me to start? But a lot of people don't ever bat an eye and they just launch in and start talking. And it's fascinating to me to see where they'll start.
Yes.
Because they start in some really interesting places and you go, now, why would they start there? But if you just let them go for a couple minutes, go, oh, and it comes around and you get a completely different picture of a person. And so that's something that I really developed in my ED practice, was coming in and doing a good patient interview first, because so often in that setting, they're really anxious, they're really nervous,
Mm-hmm.
And we dive right into our physical exams, sitting up on the edge of the table, and you come in behind them and start poking and pushing and and they're scared and they're guarded, and so they tense up. And so I found that I really kind of flipped my approach with a lot of people, and I would do a good interview first, and then I would do some education second, and then I would do my exam. And when I did it in that order, I found that I got a lot better results from people, and people would they would give me a lot more information, but they would be a lot more relaxed and comfortable in the exam. One of the stories that I told, I did an interview with Tim and Jeff on the Reframe Pain podcast. I don't think I said that right. And told a story about this lady that came in and her pain level was 14 out of 10. I'll try to make it quick. She was in a lot of pain, and the nurse had charted 14 out of 10, and which, how nurses feel about that.
Mm-hmm.
And so I sat down, talked to her, gave her some education. I was really kind of identifying some of her fears, bringing things down. I hadn't done an exam. I hadn't done any treatment yet. Nurse came in the room to do vitals and said, oh, by the way, what's your pain level? And she said, it's a 7. I'm like, oh, she just went from a 14 to a 7, which is now on the scale.
Right.
But that's fear, that's anxiety, that's loss of control. And what I've been able to do is give her a little bit of agency back. I'm not just going to come in and do something to her. I've calmed some of her fears, and I've helped educate her a little bit. And then we did an exam and did a treatment, and she walked out, really happy that day. And so that ability to connect to a person and figure out what it is what's going on. It amazed me how often when you have people that come in with acute pain, I saw tons of back pain. That's what they brought me in for.
Sure.
And that was my wheelhouse. And so I did a lot of back pain. How many people come into ED with back pain where nothing happened? I went to bed, I felt fine. I woke up this morning and I can't move.
Yes.
For how many of that type of a story, if you would just sit and listen for a few minutes, there's something big going on in their life.
Mm-hmm.
I don't want to overemphasize that it's not physical and it's always, mental or psychological or whatever, but that's a huge part of the pain experience. And when you have that person that doesn't fit any of the categories and any of the red flag stuff, and they just have really bad pain, a huge amount of the time when I just sit and listen to them, ask them open-ended questions and let them talk, there's something going on in their life. I had people who their teenage child had committed suicide, who just lost their job, and it was the anniversary of their spouse's death. And all of these things that are massively emotional experiences, but they're driving a pain experience because,
right.
And their pain's really bad, and they come to ED and think there's something wrong with them.
Have you read the book, The Body Keeps the Score?
I have. It's an amazing book. And
holy cow. Like, for me, it was very hard to read, obviously processing some personal things as I was going through that book, but and I think every human would. Man, that gave me a lot of respect for our patients who particularly are suffering from multiple traumas, whether psychological or physical or both. And I think one of the things I often say is you have to turn the car off before you can fill it with gas, right? Like you have to stop the car, you have to turn it off, you have to settle the patient, you have to make them ready before you can fill into them. And so that's always my approach. Let's turn off the car before I take a look at the car.
Yeah. I love that metaphor. Because it's so true, and we just don't do that. It was like, well, I got so much time, whether it's ED or in the outpatient clinic. I've got other people, I've got other things I've got to do. So let's get in, let's get this done. But you miss all that, and if you don't ever turn the engine off, you're not ever going to get under the hood.
Yeah, because the car won't stop.
Exactly. Yeah.
So until it literally runs out of gas.
Until it literally explodes. Yeah.
Yes.
Yeah. I had a patient in the outpatient clinic the other day that said, who had multiple traumas and ACE, and she said, I just have kept filing it away. And she said, finally, my filing cabinet exploded.
Well, there's that quote that says, like, if you don't take time to take care of your body won't make time.
Exactly.
So, I mean, my goal is to help prevent that, whether that's a patient who's coming into the emergency department because they've fallen for the first time. I don't want them to fall again. Yeah. Or it's somebody who's having their first pain experience. I see a lot of young people who are coming into the ED because they're terrified. They've never really had pain before. And they're like, holy cow, this is horrible. This must be dangerous. I don't know what to do. And giving them those coping strategies and how to manage themselves going forward. So that's definitely my preference is that we help patients empower themselves so that they aren't ending up needing more and more and more care.
Absolutely. Yeah, I totally agree with that.
All right. Well, so this is the Admitted or Not podcast. So I'm ready for a case about whether your patient was admitted or not in the emergency department and what happened. Obviously, change details as needed.
So yeah, I've had a hard time coming up with just the right one. I think a lot of us do in this case, and I can't think of a whole lot of big misses that we've had where I found something that somebody else didn't. I guess for me, one of them that I saw was he was like a 24-year-old kid that was a runner, hadn't run for a while, started running again and ramped up really rapidly on his running and was doing, I don't remember the miles, but he was doing 25 miles a week or something not crazy, a fair, but he had ramped up really fast.
Right.
And he came in with hip pain. I actually saw him in urgent care, not emergency. We had an urgent care literally across the hallway.
Ooh, I love that. That's another podcast for another day.
Well, for sure. And I floated back and forth between ED and urgent care just all day long. And so this was actually an urgent care patient. Sorry, not an ED, but
that's okay.
The provider over in urgent care said, hey, can you just come look at this kid? He's 25, his hip hurts, and I don't think there's anything wrong with him, but just talk to him before I send him home. And I asked him a couple questions, and he was having an awful lot of pain and didn't recognize that he had ramped up really fast. And I went back out to the provider. I said, you know what, I just really feel like we need an x-ray on this person just to make sure before we send him home. So the patient walked down to x-ray, had his x-ray, came back. And then I think it's a pretty obvious one, but I'll let you ask a couple of questions here.
Well, where was his pain specifically?
So it was in his groin, kind of, when you say hip, as you know, that can be.
Oh yeah, it's usually when patients tell me they have hip pain, it's usually more in the SI area. It's
So
never kind of in that
he was
anterior
having
groin.
kind of deep buttock groin pain.
Deep buttock and groin pain. And did it feel muscular to you? I mean, I'm guessing not, since he went
Yeah.
to X-ray.
No,
Okay. And he was able to weight bear.
he was weight bearing.
And did he have any other comorbidities?
He was a young, healthy man.
Oh gosh. I don't know. You're gonna have to tell me. I want to know. I'm gonna guess stress fracture would be my first guess, or that he had AVN from some underlying medical condition would be something I would consider. Or I think the last thing I have seen a lot lately are undiagnosed TAM lesions that have gotten to the point where the patient thinks they have radicular back pain because it's going, they have that sign around their hip and it's going all the way down. And it turns out it's more of a hip issue than a back pain issue. So those are my top 3 guesses.
Yeah, that's so excellent differential right there. Your first one was the correct one. He had a rather frightening stress fracture. And when I saw his X-ray, I said, "Oh my God, sit down."
Was it femoral?
Yeah, femoral neck.
Oh my gosh.
Femoral neck fracture. So obviously we put him on weight bearing. He was outpatient, but went into he had surgery the next day.
Holy cow! And did they figure out like why a 24-year-old is having that many issues?
He was a fit but stocky, a big bone guy
living in a larger body.
And he ramped up really fast. He was just he had run in the past, and I can't remember what the situation was, but he had not run for a couple of years and then started running again and just went really hard, really fast.
Okay, case in point for the need of upstream physical therapy to help somebody like that who is ready to like get back to their running program, but to do it safely so that we are preventing illness and injury. Because I'm sure he was so frustrated, thought he was doing just the right thing, getting back to being active.
Yeah. And here he ends up in surgery and off his running for a long time. Yeah.
Well, kudos to you for catching that, because I could see many providers in many different clinical settings kind of dismissing that and treating it more like a soft tissue issue for a long period of time until it became unbearable for him. Exactly. So hopefully you spared him some worse outcomes.
Yeah. But he did get a surgery out of it, but I think we definitely saved him in the bigger picture from something worse.
I love that. So parting thoughts, what I would like to know from you is if somebody is thinking about practicing in the emergency department, one question I've been getting a lot is, what do you think the number one skill you need to have is?
I think flexibility, I would say. If I guess if I just had to pick one, I think a person needs to be really curious. They need to be compassionate, and I think they need to be humble.
Yeah, fair.
Yeah, I think that, and I've heard you say this on several of your other interviews, how collaborative the ED is, and I've never worked anywhere where I had more respect from physicians than I do in this setting. The nurses, some of them love you, and some of them see you as a nuisance, but the collaborative environment, the willingness for everybody to share and respect each other's opinion. And so there's a good deal of humility, I think, that goes into it, because sometimes they'll come to me and ask for my opinion, and sometimes I'm right and sometimes I'm wrong. Sometimes they'll do something that I didn't think of, and I've had physicians say, well, you know what, I know you don't think they need imaging, but I'm going to go ahead and get it anyway. And there was something that I can't think of an example, but there was something.
Oh, sure. No, that's happened to me before too. I've been like, what? Why are you doing that?
I didn't think you were going to find that, and like we did. So I think that ability to be humble, but just the flexibility, of course, to be able to take it as it comes. Those days where you don't see anybody, and then the days where you have 6 people waiting all at once. And when I was going back and forth between urgent care and ED, and I'd have 2 beds in urgent care and 3 in ED that were all ready at the same time. That ability to say, which one can I make the biggest difference with, since I don't have very much time, what can I do quickly to give them something valuable?
Exactly.
Yeah, I just, it's such an incredible setting to work in, and you can make such a difference for people that I'd really encourage a therapist who's interested in it to explore it more and reach out to any of us that are on the list, of people in the Facebook group that have some experience. Look up the literature, because there's so much good stuff out there on the difference that physical therapists can make in emergency.
Well, and we look forward to having you join us for our journal club in August, so we can talk about some of your research about the benefits of PT and the ED.
Yeah, I'm excited to do that as well.
All right. Thank you so much, Keith. We really appreciate your time. For those of you listening, thank you for your time and attention today. I appreciate if you could like, share, and subscribe. And this has been another episode of Admitted or Not.